The last official event that I attended here was in October 2023. We were out there in the open. And that's when I opened the St. Anne Mother and Child Center. It has since welcomed more than 12,000 babies and continues to serve many mummies and their babies. Unfortunately, I was told the number of babies are coming down, not because of Mount Alvernia, because of Singapore, just having fewer babies. And today it is with great pleasure that I join you again for the official opening of the new Day Surgery Center, as well as the upgraded Intensive Care Unit and High Dependency Unit. And these upgraded facilities reflect the demographic reality we face. And Singapore has become a super-aged society this year, where 21% or more of our population is aged 65 and above. I don't know why the magic number of 65. Somehow, once you hit your birthday, 65, you are senior. And you enter the calculation of a super-aged society. And today, Mount Alvernia turned 65. So you're contributing to our super-aged status. The convergence of milestones of us becoming super-aged and Mount Alvernia celebrating your 65th anniversaries reflects how Mount Alvernia Hospital has served the Singapore population, as our nation has grown. And the hospital has had a long and eventful life journey. Dr. James Tam has gone through many of this, but let me just go through it briefly. Founded 1961 by the Sisters of the Franciscan Missionaries of the Divine Motherhood, started with just 60 beds, and for 65 years, the hospital has attended to numerous patients, supported countless families, while remaining rooted to its motto, serve all with love. And today, Mount Alvernia Hospital has over 350 beds and has extended into multidisciplinary practice. Mount Alvernia Hospital is also an important part of private healthcare in Singapore. It is also Singapore's only private, not-for-profit hospital. Not-for-profit acute hospital. Our healthcare ecosystem is diverse with services that span a continuum from prevention to rehabilitation. Across these care settings, healthcare professionals work tirelessly to restore health, prevent diseases, and alleviate discomfort and pain. They are our family physicians, hospital clinicians, specialists, allied health professionals, pharmacists, and nurses, etc. There are also Western medicine and traditional Chinese medicine practitioners, and also Ayurvedic medicine, actually. And they are founded on different principles and philosophies, and we continue to find ways to synergize them and synergize their strengths. And there is public and private healthcare too. And from time to time, I get asked the question, with government healthcare expenditure rising, more public hospitals built, is there still a role for private healthcare? The answer is clearly yes. There was a very nice quote just now between efficiency and sympathy. So likewise, I think healthcare, the spirit of healthcare, a lot of it is about being universal, being egalitarian, and public healthcare deliver that. But we cannot be so egalitarian that we deprive the public of choice of the private healthcare. Or we cannot have so much choice with different service standards that we lose the spirit of being universal and being egalitarian. We have to strike a balance. Private healthcare has always played an important role in the care for the Singapore population. It is an integral part of the healthcare ecosystem and will remain so. For example, in primary care, about half of accredited family physicians are in private practice. But most have joined national schemes such as the Community Health Assist Scheme, CHARS, and Healthier SG. They play key roles in chronic disease management and strengthening population health. Many GP clinics have also formed PCNs, primary care networks, which collaborate with public health clusters. These private GP clinics attend to roughly 80% of primary care patients. Another area is long-term care, which is fast expanding in the healthcare sector. I think it's the fastest expanding healthcare subsector. Private providers, alongside social services agencies, community care organizations, and other charitable organizations, play significant roles in operating nursing homes, senior care centers, active aging centers, and delivering home and palliative care services. And finally, in acute inpatient care, we have several private hospitals. Having private hospitals operating alongside public hospitals has been a long-standing government position. It is neither desirable nor possible for public hospitals to be a monopoly. Even in the UK, where they declare it's mostly public, you have the NHS, the National Health Services, which is so dominant, it does not have a monopoly. Because healthcare is free at the point of care in NHS, patient queues are long, and many UK citizens purchase private healthcare insurance and opt for private healthcare to skip the queues. In Singapore, there's a white paper written in 1993. I must confess, I only read it recently. It is titled White Paper on Affordable Healthcare. In that paper, it envisaged a greater role for private hospitals. It set out a long-term plan to raise the private share of acute hospital beds from 20% then to 30% by 2010. Already passed 2010. With the public sector correspondingly reducing its share from 80% to 70%. And this was so that public hospitals could focus their core public mission to provide care for the middle and lower income groups. 2010 came and went, 16 years ago. The public sector is still operating about 80% of the hospital beds today. What has changed is that the public sector now takes in an even larger share of patients, accommodating about 90% of Singapore's patients. So 80% of beds accommodating 90% of inpatients. Bed occupancy rates at public hospitals are typically quite high, over 90%, while private hospitals are barely half occupied. This is an unusual situation, given that almost 40% of Singapore residents have actually purchased healthcare insurance for private hospital care. Yet when they require hospitalization, around half of them still choose to seek care in public hospitals. So the role of private hospitals is diminishing, not due to, but despite our policy intent. What is causing this shift, unintended shift towards public hospitals? I think a couple of reasons. One, as people get older, they tend to have multiple conditions and complications. And therefore, they may prefer public hospitals where they can be cared for by a wider range of specialist disciplines. And today we have a much higher proportion of elderly than in the 1990s. There is also a cost consideration. I believe with private hospital charges getting more expensive and private healthcare insurance premiums escalating, it is deterring some patients. Patients are worried about the size of the bill that they have to pay and whether they will be successful in making insurance claims. And so they opt for public hospitals, enjoy subsidy, use MediShield Life, which is rarely turned down. Hence today, the healthcare cost gradient is distorted. We have the most affordable charges at public hospital class B2 and C wards, where subsidies are the greatest, then B1, then A, followed by private hospitals. But private hospital bill sizes have become significantly higher than class A wards, even for the same procedures, and even though both are not subsidized. Therefore, the cost curve of options is not a smooth slope. There is a steep climb from unsubsidized public to private hospital care. The next question is, what led to higher costs in private hospitals? One major driver is insurance. Insurance riders have become too generous over the years. They offer total peace of mind and became the plan of choice for the large majority of our population. But this triggered off the tendency for people to use more than necessary and providers to serve more than necessary. And it is just human nature when someone else is paying the bill. And this has fueled further rises in private hospital costs. The strong coverage offered by private health insurance also supported a private hospital operating model geared towards high-end care. The last time government tendered out land for private hospitals was some 20 years ago. I think we all remember which one. The land was won with a high bid price, and today we have a high-end private hospital occupying the land. In the process, public healthcare also lost many good healthcare professionals to the private hospital, which was very painful for us. That experience has made the Ministry of Health very cautious about having more private hospitals, and for the matter, very cautious about private hospitals expanding. You have experienced it. Yeah? We now realize that total peace of mind is very expensive in more ways than one and has resulted in an unsustainable situation. We are therefore taking steps to narrow or fill the cost gap between public and private hospitals. We are tightening the design of private healthcare insurance riders to refocus them on providing assurance against the very large hospital bills rather than the small bills that's covered by deductibles on Medisave. This means moving insurance riders away from total peace of mind proposition because it leads to escalating premiums, which over time actually cost patients even more. These new requirements came into effect earlier this month, and I hope policyholders, in consultation with your financial advisors, will consider if the new policy riders meet their needs better and help them save costs. Next, we encourage the establishment of lower-cost private hospitals. Not all private hospitals are high cost or need to be high cost. Mount Alvernia Hospital is a very good example. From time to time, I actually get members of public writing to me, asking me, why do certain unsubsidized treatments or diagnostic scans in public hospital cost more than those in Mount Alvernia? It's slightly embarrassing when I receive those. Yok Yang, you take note. You are therefore asserting competitive pressures on public hospitals and keeping us on our ball, which is good. But we only have one Mount Alvernia, and we wish for more private hospitals like you. That is why I had earlier announced MOH's plan to establish a new not-for-profit private acute hospital to provide another lower-cost private healthcare option. To this end, the government intends to release a plot of land for this new private hospital in the eastern region of Singapore. If we do proceed with this, it will be the first land release for private hospitals in almost 2 decades. It should be adequate for 300 to 400 hospital beds. And to provide for a lower cost option, we intend to stipulate certain requirements in the tender documents. The first is bill size restrictions, so that the hospital bills are a certain percentile of the market and cannot lead the market. The second is to adopt a fixed price land tender approach. Under such a model, bidders will then compete not based on how much they are prepared to pay for the land, but other qualitative factors such as their care model, cost efficiency, approach to recruiting and developing manpower, and their commitment and policies towards affordable healthcare. MOH has been consulting many stakeholders on this not-for-profit private hospital. We have encouraging responses from potential operators and also enthusiastic donors and philanthropists. I believe we can make this a good project that will strengthen the healthcare ecosystem and involve many stakeholders outside of public healthcare. There are still a few important issues we have to address, and I hope we are able to address them and arrive at a decision in the second half of the year to launch the tender. And on this hopeful note, let me conclude by thanking Mount Alvernia Hospital again for demonstrating that social mission is a key driving force behind good quality and affordable healthcare. I thank Mount Alvernia Hospital's leadership, staff, and partners for more than 6 decades of service. May you have many more years of serving people and alleviating pain and discomfort. Congratulations on your 65th anniversary. Thank you.